Next session will be state-of-the-art lecture. Professor Omata, please.
Yes, this is a state of art by Professor Ji-Don Zhao, and I'm Dr. Omata. I'm very happy and honored to hear Dr. Ji-Don Zhao's lecture on the update on the management of primary biliary cholangitis. I think he's the one in this field for many, many years, especially along with the study on the fibrosis. And as you know, so many development of the treatment of the fibrosis now coming. So maybe next 5-10 years is maybe more like the treatment for the viruses. So I think there are so many diseases that with unknown etiology, but tonight Ji-Don may update us. So Ji-Don Zhao, please.
Respected Professor Omata, dear colleagues, ladies and gentlemen, it's really a great honor for me, thank you, to be here to speak to you about the management of PBC, something old, something new. Well, first of all, I would like to thank the President Shia invited me to this wonderful meeting in a wonderful city at a wonderful season. And of course, also held by the wonderful people. Well, it is well known that primary biliary cholangitis, so-called PBC, I would say it's a common disease among the rare disease. It's rare, but it's, the common is the rare disease. So from this slide, we can see there's autoimmune hepatitis, PBC, and PSC, sclerosing cholangitis. Among these three, this is in the middle, this is the most commonly seen in clinical practice. I will just very briefly show you the epidemiology. These two slides, the two meta-analyses prepared by my colleagues. The left side is the worldwide. We can see the prevalence in the worldwide. In North America, the highest, 218, Europe in the middle, and in our Asian Pacific region, they're lowest compared with the Western countries. So the right one is just within the Asian Pacific region. We can see within this region, China and Japan have a highest, and the New Zealand in the middle, and Australia and Korea in the lowest. I have to say that all these data are not really population-based screening or survey, just kind of a summary of the clinical reporting. So they may not really reflect the true prevalence or incidence. However, what we are sure is that this disease is much more common than we thought before. So this slide, just the schematic showing the autoimmune pathogenesis. It is very complex. Like all autoimmune disease, we have genetic background, we have environmental triggers. Of course, we also have the changes of the immune regulation. So actually this slide adopted from the APASO guidelines, co-authored with all these professors, Professor Mata, Professor Tanakawa, and also my colleagues. So this just schematically showing that somehow our T cells and directed autoimmunity against our bile duct cells. Well, this is small interlobular bile duct, not the big, large bile duct, not the canaliculus in the intermediate size. Perhaps this picture showing this is a canaliculus, this is a larger bile duct, this is the interlobular bile duct. This is a site where the autoimmunity attacks. You can see that's a typical picture of destructive interlobular cholangitis surrounded or infiltrated by a lot of lymphocytes, even fill the follicles. So this is a typical pathological lesion. Whereas clinically, we can see it mainly affects middle-aged women, but now we see more and more young ladies also have this disease, because now the routine screening with biochemistry in the health check, we found a lot of patients with very early or preclinical stages. The hallmark of biochemistry is also very simple. The remarkable elevation of ALP and gamma GT, at the same time, the elevation of IgM. Then the autoimmunity, as evidenced by the autoantibody, anti-mitochondrial antibody, especially M2, and also we have some antibody, anti-GP210, SP100. All these three antibodies we call PBC specific, although it's not 100% specific and sensitive, but this is rather specific. The pathology already mentioned, this is non-purulent destructive cholangitis of intralobular bile ducts. So this is the clinical features of PBC. It's well documented. Now this is the natural history. It's showing, you can see, we do not actually know how long, very long or rather long preclinical course. There are no any clinical symptoms, maybe no abnormality of biochemistry. Then gradually, first you have the elevation of gamma GT ALP, but maybe perhaps still no symptoms. Gradually, you can see as the cholestasis progressed, then fibrosis and eventually cirrhosis may also progress, developed. So finally, from preclinical to clinical to pre-cirrhosis to cirrhosis, from compensated cirrhosis to decompensated cirrhosis. So this is the natural history, you can see. Well, at the end stage, of course, liver transplantation is the only resolution or ultimate treatment for this kind of disease in old days. But now, since we have treatment of UDCA and other treatments, perhaps the natural history, the clinical course will be modified a little bit. However, even after liver transplantation, we still have a number of patients, maybe around 8 or 10% of patients still have relapse even after liver transplantation. So this is what we are understanding. Now, I will just briefly, again, I show you in the APATO guidelines. You can see the diagnosis is relatively straightforward, because in clinical practice, we see elevation of ALP and gamma GT. At the same time, we do ultrasonography to exclude the extrahepatic obstruction of the liver. Also, we needed to excluding the drug-induced liver injury, as the previous session talked about. If we can include both of these, then of course we test the AMA and these three antibodies: AMA M2, anti-SP100, anti-GP210. If they are positive in this setting, already we can make diagnosis of PBC, even without histology. Of course, if these antibodies are negative, we need to do liver biopsy. Otherwise, the clinical diagnosis is not reliable, because there are also so many other diseases could cause elevation of gamma GT and ALP. So, of course, for others, if we already have some sign of the extrahepatic bile duct dilation, of course, we need to do imaging or endoscopy, try to excluding other diseases. So it's relatively straightforward for the diagnosis in a clinical setting, in patients with elevation of ALT or gamma GT, in the absence of extrahepatic biliary obstruction. However, what I would like to say, just one sentence, in clinical practice or in, we need to be careful. The positivity of antibody alone does not support diagnosis of PBC. Now we see more and more cases somehow they check the autoantibody for other disease or even during the health check. Then we follow up this kind of patients for 5, 8, or even 10 years. Still only very small percentage of patients develop clinical PBC. So we need to have the elevation of ALP, gamma GT. We need to have either have biochemistry evidence or we have histological evidence. We cannot rely on the autoantibody only. So now, the next 20 minutes, I will focus on the treatment of PBC. Wow, something old. First, we talk about something old. UDCA, also deoxycholic acid, have been proved for this disease for already several decades. It had been the only first-line treatment for many, many years. Still, this is the only available first-line therapy in many parts of the world. Of course, I have obalic acid. This approved in States and Europe, but not approved in many parts of Asian countries, including China. But now we are doing clinical studies, trials, to try to get the approval in China. Then we have off-label use of fibrate, like benzofibrate or fenofibrate. All this, the PPAR agonist used as off-label in those patients who are not responding well to UDCA. So this is the almost standard of care. So I would say something old. I won't touch this too much. I will focus in the next part of talk on something new. Well, many other new PPAR agonists, including lanfibranor or seladelpar. These two finished the phase 3 study. Hopefully, I heard, just a rumor, maybe they get approval in States or Europe may by within this year. But that's just a rumor, I'm not sure. So I will talk about this. Then we have some other new FX agonists. We have F19 analogs. We have NOX1 inhibitors. Finally, we have ileo bile acid transporter inhibitors. So this is relatively new, but already in clinical trial stage. Of course, we still have many, many new formalities that are still on the preclinical or very early state of clinical study. I won't touch that. I just focus on this relatively phase 2, phase 3 study. So now this is the guideline for something old. Of course, first line, we use UDCA. Then we can assess the biochemical response at half a year or at 1 year. If it is good, then we continue the monotherapy with UDCA. If they're not good with suboptimal or unresponsive to UDCA. If there are no pruritus, then we can use benzofibrate or fenofibrate or obalic acid. If there is pruritus, we can use only benzofibrate because obalic acid have a very, very important drawback that is cause pruritus itself. So this is also from our EPASO guideline. We hope you will sign it. So this is a criteria for the biochemical response assessment. Usually we use Paris 1 for the advanced PBC, for Paris 2 as the early PBC. However, recently, a lot of studies using the Toronto criteria. That means 1.67 times upper limit of ALP abnormal. If cannot fulfill this, cannot lower this, we say this suboptimal. So this is used by a lot of clinical trials because it is just consider ALP. So now, the second line, though still something old. How can we, this is a study from, mainly from the Europe, UK, you can see. That's the study. Some use LCA, that means obalic acid, some use fibrate, like fenofibrate or benzofibrate. You can see, actually, they have, in terms of reducing ALP, then actually fenofibrate, fibrates have better efficacy than the obalic acid. Whereas in normalization of ALP and the bilirubin, of course, the obalic acid is better. So, of course, if patients have pruritus, they cannot tolerate, usually cannot tolerate the OCA. So this is what we already have. This is proved, this is not proved, but we can use off-label. So this is the current sense. This slide just showing more and more now we try to have to get adequate biochemical response to want to have a so-called deep response or completely normal of alkaline phosphatase. From this study, we can see that those with completely normal of ALP, they have a better long-term survival than those. They are less than 1.5 times upper limit of normal. So we want to have a more stringent criteria for biochemical response. So that's why we need to use something new. That will briefly address these categories. First of all, this is a little bit complex, very basic slide, just showing there's a potential targets of novel therapy for PBC. Well, you can see the pink, I would say the pink purple ones as PIPA, alpha, delta, or gamma, or this kind of thing. Another one is FXR, this receptor, nuclear receptor. So this is two major categories. Of course, we also have inhibitor of ilio bile acid transporters. We also have some other things. So I will go through this. So nowadays, for something new, for gene therapy, for immune therapy, this is just not really in clinical study or very early clinical study. Nowadays, what we use, PIPA agonist or FXR agonist or FGF19 analog. Now, we also have some clinical study of NOX1 or 4 inhibitors. We have some preliminary studies on the ilio bile acid transporter inhibitor. So I will just address this. This is, again, this is just a classification of the PIPA receptor. Well, see, we have alpha, we have delta, we have gamma, and we have delta. They have a modulation of bioproduction. They may suppress the immune reaction, or they modulate or suppress the inflammation, or even they decrease the fibrosis or steatosis. So in one word, they have benefits. So this is currently used. There's old ones like fibrate, benzo, and fenofibrate. That's the old one. That's the non-fibrate ones. As I showed, there's 3 ones. There's Selanderper, then seroglitide, and elenfibranor. So all these 3 have clinical studies. I just want very briefly showing this one. This is the PIPA alpha, delta, gamma agonist for, they called seroglitide. Have phase 2 clinical trial. You can see after 16 weeks, because it's relatively short. This placebo group, that's different doses. We can see the declining in the ALP. Similarly, we can also see the declining in the gamma GT. However, ALT elevation occurred in 7% or even to 20% of higher dose group. So maybe that's one of the concern for this study. Now we have, as I mentioned earlier, it's called additive start trial. It is phase 3 one. This year, just published in New England Journal of Medicine, elenfibranor. This is alpha delta, dual agonist. In treat patients who are with suboptimal response to UDCA. I can see they can not only improve the biochemistry, but also somehow they could improve the pruritus, but it's not statistically significant at this time. So that's a 1-year therapy. So this is a very important study. Well, we also see some adverse events, abdominal pain and diarrhea and nausea, and also have some even worse severe adverse events in this group. So this needs to be continually monitored during the later clinical trials. Then we have another one. We have also finished the phase 3 study, Selanderper. Selanderper, you can see this is a delta agonist. It's a mono for PBC. We have phase 2, we don't touch already. We talked last year. Now this year we have 2 phase 3 studies. One is enhancer, one is response. Response just reported recently. We can see that's the enhanced study reported last year as the hepatology. You can see they can improve the biochemical response defined as ALP lower than 1.6 ULN, or at the same time they need to drop by more than 15%. At the same time, they have a normal bilirubin level. So this is called composite endpoint. Both of the studies use the same thing. You can see this is a placebo group, there's a different dose group. We can see both of this group have significantly better or higher rate of biochemical response. That's a normalization of ALP is relatively low, although this is drop we can see, but the complete normalization is still not that much. So then enhanced study, another study, the same medication. Also, we can see that's the 3 months. No, that's the same study at the 6 months. 6 months, we can see again they have a better efficacy in ALT, the ALP. This is the absolute value. This is the relative change. We can see. Now we have 1 year study. We can see 3 months, 6 months show efficacy. So another response study. They have the phase 3 study, 1 year study. You can see again, this is have better biochemical response. Still, they use a composite endpoint. The normalization rate increased. It's 25%. It's still not very high, but increased in most of the patients. So that's the currently study. While response study, we can see that's the pruritus. The pruritus improved also by saline diaper. So that's a very important development, because the pruritus can be caused by disease itself. If the medication still also cause the pruritus, it would be not easily accepted by the patient. So I talked the 2 very important ones, both finished the phase 3 trial. They published in the New England Journal of Medicine just maybe actually last month. Now we talk another category, farnesoid X receptor called FR receptor agonist for PBC. I just show you one. We already have publication, tropifexor, or finished the phase 2 study. You can see this is, of course, it's an agonist for FXR. It could improve the gamma GT and AP levels in PBC patient, but they have the adverse events. They can cause pruritus. So this is a little bit of concern, I worry about this medication. So this is, of course, there's a gamma GT, the LP. You can see compared with the placebo group, then the higher dose group have a better efficacy in declining these 2 very important enzymes, reflecting the cholestasis. So then we talk about another one, new category, FGF19 analog. This is a phase 2 study. Of course, this just a very short time, just 42 days. Again, we can see the ALP levels, gamma GT levels could be declined, especially in the higher dose group. Then the ALT, then the AST, they also can be seen. So they can both improve the bile ducts, so-called biliary enzyme and our hepatocyte enzyme. So that's a very early stage. Then maybe another one is NOX1 and 4 inhibitor called statenexib. It could improve the biochemistry, showing here, like this one. And also, they can decrease the fibrosis burden, but it's not by histology. This is by non-invasive test, by VCTE, vibration controlled transient elastography. You can see showing this is just a phase 2 study, have no phase 3 study. So almost lastly, we talk about this category, ileal bile acid transporter inhibitor. Well, this is very important. You can see actually our bile duct will reach the duodenum, ileum, where it could reabsorb in so-called the gut and the liver circulation. So this is very important. If you block here, then maybe bile acid could not be returned to the portal vein. So block this, hopefully will reduce the cholestasis. So that's the mechanism. So there's a GLIMMER study, so-called GLIMMER, phase 2B study. It's an RCT, called linear reciprocs. It's very complex. I don't know how to correctly pronounce linear reciproc. It could improve the pruritus in this study. Well, you can see this is a change mainly in the worse daily itching. So you can see if it's lower, the better. Well, this is changing in monthly. So from this slide, we can see they can reduce either daily or monthly scores of the itching. We can say that's the itching scores. So the patient, of course, still have some problem with diarrhea or abdominal pain, which is the main AE that causes discontinuation in some of the patients. So this is a very promising one. Then lastly, we have so-called Clarity trial. That's another IBAT inhibitor called maralixibat. I have other names for patients with pruritus due to PBC. However, we can see this study didn't really reach the statistical significance because the placebo group also have very good efficacy, nearly 50%, while treatment group only slightly higher than. So reason is not so clear. So they discuss in this paper, while this is, we cannot say that failed, but they say they provide very important insight for the future clinical study trial, design of the trial. Currently, of course, it cannot see the efficacy because they have the similar efficacy on the pruritus as the placebo. So ladies and gentlemen, in the next 1 minute or 2 minutes, I just summarize what we have. Something old where we know UDCA may be effective or have good response in 60 or 70% between, something like that. In those with unresponsive or suboptimal responsive, we could add either obeticholic acid or with off-label fibrate like benzofibrate and fenofibrate. For this, I think Professor Tanaka also have very good study that could not only improve the liver biochemistry, but could also prolong the survival. Due to limitation time, I didn't show that slide. Well, for something new already, that's mainly PPA alpha delta or PPA delta agonist. 2 of them already passed the phase 3 study. Hopefully, they can get approval in the near future. Then for FR agonist, for the others, they show very good promise, but the clinical phase 3 study is still not there. So we still do not know. So in summary, the first line therapy, again, UDCA. Then if there's suboptimal therapy, we can use either of this. Then, of course, that's the investigational drug. We cannot use in clinical practice, but we encourage the patients to be recruited in this clinical study that we also have patients. I'd like to thank my teams or clinical team, the young doctors, and also we have laboratory study team, all the scientists that work on this, help me to do some clinical research on the PBC. And lastly, I would like to thank all the professors like Professor Hiscolt, Mans, and Paul Garner, and Gershwin. All these professors help us to understand this disease. We saw that's a Western disease. We learned a lot from them. So I thank, of course, also my mentor, Professor Wang. He introduced me to this world top classes of professors. I thank them for their inspiration in the field of PBC. For last but not least, I would like to welcome you to Beijing, the next year's annual meeting of PESO on behalf of Professor Lai Wei, who is the president-elect for the next year's meeting. Thank you.
Well, wonderful talk as always. One thing I just ask you that you are the specialist for the fibrosis. So how do you think about this nowadays? We are going to have a nice anti-fibrotic drugs. So that can be introduced in this area. How do you think about it? Because target is now lowering the ALP and gamma GT, but at the end, got to improve the fibrosis.
Yeah.
So maybe that can be applied for this entity. How do you think about that, specialist?
Yeah, Professor Amat really pinpoint the question. Actually, for PBC, we can have the patient have normalization of biochemistry. Of course, those with normalization have better clinical outcomes than those without normalization of LP. However, even in those with normalization of ALP or gamma GT or any liver function test, they still have portal hypertension, they still have fibrosis. Maybe that's what we need. Unfortunately, at the moment, in addition, except the antiviral therapy, which is very effective for the hepatitis B, hepatitis C induced fibrosis, all the other, well, we have no specific therapy for fibrosis itself. Although my professor and also the professor I mentioned, some of them, they studied for decades. The problem is we cannot identify single one, the single critical trigger or the single pathway. In the actual ex vivo, in vitro study or animal study, we can show very beautifully the data. But in clinical practice, it's really very, very difficult. Maybe because the disease is complex. And another thing is that the evaluation of the fibrosis progression is not easy in a short period of time with non-invasive ones.
Yeah, I know the hundreds of failures against antifibrotic, but about a month ago, FDA approved the one, and then there might be the second one pretty soon. So it's becoming, reality in the area of the fibrosis. So that's why you'll be there, not just lowering ALP or gamma GT. But in that context, you mentioned about pruritus. You briefly touched upon by saying maybe this is related to the etiology or the pathogenesis, by preventing the pruritus. And then that way, if we have a drug, we can probe into the real pathogenesis behind. How do you think about it? Yeah, not just simply, I mean, it's nice to see gamma GT elevation, ALP, it's a diagnostic purposes. But in terms of the real underlying mechanisms, maybe we can probe into by using the drugs. So you mentioned that about the pruritus, right? There is a certain drugs try to prevent the pruritus, reduction, the degree of pruritus, itchiness, right? So that you said that.
The pruritus actually cause the patients the very bad feeling. Also, they have the damaged quality of life. Even in America or Europe, they say the indication for liver transplant, one of the indications is refractory pruritus that severely affect their quality of life. So this is also on medical needs. Although some medication try to block that pathway, at the moment try to block resorption of the bile acid. But we still knew. In China, one China scientist, actually 2 weeks ago in China, we have a meeting. They claim they found something, the new mechanism of the pruritus. Perhaps if they can successfully translate that so-called therapeutic target, the finding to therapeutic target and to development of medication, perhaps we can have big step forward.
Well, anyhow, next year, Beijing, I'm looking forward because there's new improvements and then new drugs coming.
Thank you.
So, thank you very much. I close. Oh, sorry. Yes. Yeah. You want to take? Sorry, this is a state of art. So, but please go ahead.
So actually, there are some new development in the pathogenesis of pruritus in PBC. Earlier, this was thought that this is because of deposition of bile salts in the skin. But now this is going in the other direction. This is because of the stimulation of nerve endings. It is not totally at all related to the deposition of bile salts. So there is a role of opioid antagonist in preventing the itching in PBC. This is not totally related to bile salt, solely related. This is because of the stimulation of nerve endings. So the another approach to prevent the pruritus is to block these nerve endings through opioid antagonist. So I have treated 2-3 patients, and it is really difficult to tackle this. Obeticholic acid is useless. UDCA is not working very well, and I have given rifampicin. Rifampicin,
Yeah.
it has shown some response for
Yes.
some time, but again it starts again.
Yeah.
So this is the new development in the pathogenesis that earlier everybody was focusing on the bile salts. So this is the new thing.
Yeah, I agree with you. Yeah, you correctly point out bioassays is just one aspect, not all. They claim they found the receptor, the special receptor for protein, for pruritus, for itching. Really very interesting. They say different disease cause different itching. The receptor may different. I hope this kind of really scientific finding, new finding, will be translated into clinical use. Thank you.
Well, I close the session. Thank you very much.
Thank you.
谢谢。
Thank you very much, Dr. Omata and Dr. Jia. Now we will close day 3 all program of room 12. Also, we have announcement.